Thank you for that wonderful introduction. I appreciate the opportunity when Skip invited me, and a few weeks ago I asked him, well, what should I talk about? Because I was a little bit concerned about the hostile reception I would receive being from Oxford, Mississippi, even though I do not have any formal connection with that school up the street. But I wasn't sure what would be possible to talk to you about without having these glaring stares at me. And the reason I was concerned is my wonderful niece Amanda Sutherland just took a position with your Attorney General here in Arkansas. And the first time she put out her hottie toddy cup on her desk, I understand they closed down the Capitol. And Attorney General Daniel decided they had to leave for the day because of that insult. So everything, fortunately, is now squared away, and we're on good terms. She has a little spot that's designated on her desk that she can use for her Ole Miss cup. But what Skip suggested that I talk about to deflect this hostility, first of all, U.S.-Iranian relations. This project, in fact, is deeply involved in a track two way to help build bridges between our two peoples. Also, how the healthcare system works in Iran. It's very fascinating, the history and what they've been able to accomplish with not much money and under some pretty dire conditions over the past 30 years. He wanted me to talk about how I got involved in the project, about our trip to Iran last year and our Iranian colleagues coming here to Mississippi. Also to talk about U.S. healthcare reform and the potential impact the Health House Network can have on helping achieve that, and some advice to those of you who are students who are going to work in non-governmental organizations, NGOs, about what we've learned through our exposure and experience with NGOs. And I'm supposed to do all of this in 20 minutes, so I have to get started. The background of this effort and my participation really began, it's a 7 degrees of separation kind of thing, with President Clinton. Because in 2000, early 2000, I was involved in a number of international science projects in Eastern Europe. And I was invited by the White House Office of Science and Technology Policy to serve on a committee to promote global science exchanges. And that was, of course, President Clinton's administration. And one of the projects that I was working on spun off into one that in 2004 in Germany, I had the opportunity of sitting down with a group of Iranian civil servants from the Ministry of Labor and Social Services. This was an unofficial conversation, just like we were sitting down at a table and talking about world things. We didn't talk about politics, we talked about concerns for our respective peoples. They were very fascinated with our educational system, and we talked about universities. I mentioned the University of Arkansas, of course. But one of the things that they told me that really was a key was they showed great pride in talking about their primary healthcare system in Iran, and that was the first glimmer of something truly unique had happened in this country. The other thing that the conversation gave me was really the basic substance of U.S.-Iranian relations, the fact that when it comes to people issues, there are no issues. The Iranians and the American people should be friends. There just is no reason why we should have this impasse. And if you look at the history, and this is something that I strongly urge those of you who are interested in this conflict, which is certainly a front burner issue in this day and age, is if you look at the history of the relations between the Iranian government and the U.S. government from the first 50 years of the 19th or the 20th century, from 1900 to 1950, it was all about the U.S. was helping the Iranians try to build their government and try to build their nation. In 1950, the Soviets, after World War II, had garrisoned a number of their troops in the Azerbaijan region of Iran and were refusing to leave, but President Truman issued an ultimatum to Stalin, say you need to leave, because that was our agreement, and they did. But then comes 1953, and the CIA coup to overthrow Mossadegh, and that's when everything started to go downhill. We had a love affair and then betrayal after 53. And we've been dealing with the betrayal part for over half a century. But comes to the people of Iran meeting Americans, we should be friends. That's all we got when we went over there and what we've heard. So what started out as a solution to the systemic health disparities problems of Mississippi has led to an international goodwill project that I was told by a recently retired senior official at the State Department that this project is like a delicate flower. It needs to be nurtured so it can grow. And I said, no, it's like a prickly cactus plant. We're tough, we can survive in harsh political environments, and we're ready to stick it to the status quo. That's what I'm going to talk to you about today. How did this start? In 2007, I was asked to do an assessment of a small rural hospital in Mississippi that was headed on to bankruptcy. And I looked at all of the specifics of why their situation was the way it was, and clearly there were problems with unreimbursed emergency room visits and all of the specifics that we have just heard over the past year and a half as it related to health reform and the problems that we face in this country. And I also started looking at the bigger picture as it relates to Mississippi. And if you look at the statistics, that over the past 40, 50 years, the health indicators, the outcomes of, in terms of obesity, of diabetes, of all of those things, the health indicators, Mississippi has been dead last, or next to last. It's trading back between Louisiana and Mississippi most of the time. And it has the highest rate of chronic diseases, low birth weight babies. I mean, you name it. It's a horrible situation, especially in the Mississippi Delta region. But this is despite the availability of many rural health facilities and hospitals and so forth, and the expenditure of hundreds of millions of dollars over the past number of years. The per capita expenditure in Mississippi last year was ranked 4th in the nation of the dollars spent per person. But still, the statistics remain flat. Why? Something didn't make sense with all this money being expended. And then you look at the broader picture of the United States, that Americans spend twice as much as residents as other developed countries. I mean, you know these numbers. You know the debate. There's something wrong, and there's something wrong with the system that we provide our citizens health care, especially those who are in poorer areas of our country. They have been left out by the system. So we needed to look at a new way of structuring how we deliver health care, especially in Mississippi. And that's what then, as I began to look at the situation and remembered what the Iranians had said, and in 30 years of the Iranian healthcare system, they eliminated to zero health disparities between the rural and urban population. In Mississippi, it has not changed. Why? I mean, it just doesn't make any sense. So I started looking more into the specifics of this program that I had been introduced a few years previously. And what dawned on me is the Delta region of Mississippi is like a developing country. It has the same economic situation, the same lack of access to services. So we were applying developed country systems to an area that was not a developed country in its conditions, and especially the way that the people, economically and other disadvantages, a legacy of discrimination, economic problems. It could go. That's another lecture. I won't verge off into that. And what the World Health Organization has promoted for areas of the world like the Mississippi Delta is this three-tiered integrated delivery network system where you combine primary and preventive care as the access point to clinics and physicians and then to hospitals. It's that integration that is critical. You got a system, someone enters into that system, and you're able to, within that integrated network, provide them with the care that they need. But more importantly, with a preventive care program, you can help them avoid getting sick and avoid the costs of care. And we are very fortunate that the World Health Organization is teaming up with us in the implementation of this project. And what they were saying is that primary health care, which is what they're advocating with this system, is not for just poor populations or poor countries. It's for rich countries as well who need to change the way they do their work. Okay, what is primary health care? And I want you to start thinking differently. What we normally think of primary health care in this country is primary medical care. In other words, the doc is that entry point. But what if there's a region of of Mississippi that doesn't have a doctor? What do you do then? In one county, Carroll County in Mississippi, there's one doctor for the entire county. So primary medical care is not feasible in this developing country kind of area. So if you redefine it to primary health care as being prevention and education, then that shifts it from the burden of getting a disease to preventing a disease. And one other point that's really resonated when we talk to the poorer residents of Mississippi, primary medical care is about what's wrong with you. You're sick. You've done something wrong. And this is what these people have been told their entire lives. There's something wrong with you. You don't have a job. You're poor. You can't, and you're at the bottom of society. Primary health care is about what's right with you. In other words, what you can do to be empowered to take charge of your health. And that working through the health house system is how we grow people from being diseased in their attitudes to being healthy in their attitudes. And that can lead to going and getting training for a job or improving their homes and so forth. It's a different way of looking at health. It's not medicine, it's prevention and education. And primary care is also based on the responsiveness to the people's needs. It's not what the corporations want to sell. We were just having a conversation before this, and you know, when you don't have many diabetes patients, then you're going to cut out the expenditures for the dialysis machines or for the amputations or, you know, you name it. We're based upon money. And the sicker people are, the more people make the money. But the suffering and also the fact that we cannot sustain these costs in this country, that's what primary care is all about. Helping people live better lives and doing it for less cost to the system. So this is these are the basic points of primary health care that all started with the Declaration of Alma Ata in 1978. If you don't know it, students, go look it up. Very, very critical. And the Iranian primary health care system design was praised by the World Health Organization and the World Bank. I did not pick this out of the sky and say, let's go to Iran. No, they say that's where you need to go to learn how to do this. So we went to Iran. My colleague, Dr. Aaron Shirley from the Jackson Medical Mall, and I went to Shiraz University at their invitation in May 2009. He's the guy on the right, of course. Dr. Shirley is 77 years old, has been through it all in terms of trying to bring health care to the poor regions of Mississippi. And he said that in 40 years I've had no success, and now he feels like there's hope with what we're doing. So Shiraz is down, you can see it's in the southwestern part of the country. Beautiful, beautiful city, wonderful, go there. Shiraz University manages the primary health care system in Fars province. The listing of the students in the hospitals, so it really knows what it's talking about, these people, in terms of the operations of primary care. But also the primary care system in Iran is over 17,000 health houses for a country of 70 million people, over 30,000 health care professionals, and 60% of those are women. And the main interest to me as it relates to international politics is the Iranian primary care system is considered above politics by the Iranian people. They don't touch it. Don't touch my health care system, because this is what has given the Iranian people this almost universal care, which they will not let be touched. And the other thing that's important, and what the State Department and our friends in the international organizations have now understand, that the primary health care system has been a key driver of social change, not the Green Movement, not the others that have been railing against the system. I mean, I don't want to comment on that. But the primary care system has caused so many changes within the fabric of society that they are a key player, and they're the key player we're working with. This is an important for down the road of how we've been able to grow this project within Iran itself. We visited with the key experts of the primary care system at Shiraz University. When we got there and we explained what we needed from them, it was open arms. What can we do to help? And they have been helpful for a long, long time as we've been working with this project. Then we went to rural areas. We went to a rural health center and a health house in Khan Zinyan, which is about 60 kilometers west of Shiraz. And these health facilities are, very, very modest, even less than modest, but well-staffed, the personnel tremendous, very eager and interested. And an interesting thing as far as how we were dealing with the Iranian people, we got there unannounced, we didn't have a minder, we just went with our friends from Shiraz University. And when they explained to the people there why these Americans had showed up and we wanted to learn from them. One of the little guys, I mean, it was translated later, he said, "This is a miracle that the Americans are coming here to ask us for help." Then another guy said, "I always knew that rain fell down, but I never knew it could fall up." This has been the subtext of our working with the Iranian system. The Iranians have also developed a very simple health tracking system called the vital horoscope. It's just because it's the wheel of the zodiac, it has nothing to do with that kind of horoscope. But what they do is each health house has this document that's on the wall, and they fill it in every day about what the community health worker has found out about going in the community. So it's real-time assessment of the people in that village or that rural area of the health indicators that they're finding out. I mean, this was wonderful that they had that active real-time input, and so they could determine what do we need to do ahead of time because there's a problem area and little farmhouse down the road. We need to look into that. Then we went to a small health house in a outlying village, and at that particular time there was this young mother and her child, and it was their monthly visit to the health house to be weighed, to be assessed. And you know, once you look at that, you can't really see that face of that child. That melts all politics because it's all about that. People helping people. Then another interesting place we went in Shiraz itself was called the Shiraz Oral Health Garden. And this is a dental facility that essentially was a way that the Shiraz University had figured out how to get around the private dentist restrictions within Shiraz itself because this wasn't a rural area. So they created this oral health garden, which essentially was about teaching education lower income students about dental health. One of them asked, the students started grilling us, and instead of about politics or international relations, they asked me how many times I brushed my teeth every day. Kids will be kids. But this is, and the people the students, the young staffers who worked there were dental students, enthusiastic, committed, and wonderful. And they really enjoyed their work. And the money shot of the trip, you can't see it, but there was this one dental student there, and all he wanted to do with us is do the Obama fist bump. And Dr. Shirley, this was part of all the media reports that we had. This was the shot that they ended the stories with. And the look of joy on this young man's face of doing the Obama fist bump with an African American from America, his life has been made. I mean, it just lit up and everything. I think this is online now on the Clinton School website. You can see this presentation. Then we met with the two founders, the real architects of the Iranian primary healthcare system, Dr. Hossein Malak-Afzali and Dr. Kamal Shadpour. And these are the two guys that during the Iran-Iraq war, when they were designing this system, had to get in basements in Tehran and work by candlelight when the bombs and the chemical weapons were being dropped. And somehow they figured this out under the direst conditions. Dr. Malak Afzali and Dr. Shadpour also have come they came to visit us last October, and will be back again this fall. And I think Dr. Malik Afzali would be a good one to invite to address the school. He won the UN Population Award. He has a green card, so he can go wherever he needs to go. Then just sightseeing, of course, the obligatory, here's what we saw. On the left side, this little child, this was in Isfahan at a park, and the little boy wanted to do the Obama fist bump. And we had to teach him. He just kind of wasn't really adept at that. So this was the first attempt at trying that. And then we went to, of course, outside of Shiraz, the King of Kings area. And I think this was a commentary by the guy taking the picture that both sides of especially the Iranian government, was tilting too far to the right. So I think that was a subtext here. The bottom left, we were introduced, or several young Iranians said, "Are you from America? Welcome." Same approach. Then a true pleasure for me experience was to visit the tomb of Sadi, the Iranian poet. And of course, what he wrote is on the walls of the entrance of the Hall of Nations at the United Nations. Human beings are members of a whole in creation of one essence and soul. If one member is afflicted by or with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. Truer words. Then in October last year, it was the Iranians' turn to come and visit us. And we had a conference at Jackson Medical Mall in Jackson, Mississippi on health disparities, local challenges, global solutions. Dr. Malik Afzali in Shadpur and other officials from Shiraz University showed, in the boon of all of us on either in Asia or in the United States, is how do you get the laptop to work? Oh, PowerPoint. Then we took them to Greenwood, Mississippi, bottom left, where we're establishing the first regional health house in our network, and they met with the community people, and they love blues music. Now some more specifics. Here's what I want to talk about. The Iranian healthcare system has been built upon very measured programs over the years that help them to define the best way to provide services to rural areas and impoverished areas, poor people. They started out with a training project in 1940, right after the end of World War II, when immunizations were important, and doctors, medical students were obliged to work in villages as part of their training, and this stopped when they had to shut down the training center. The Health Corps in 1964 assigned medical and graduate students to go serve into the villages, but one of the first things that they saw was resistance among the villages themselves because of the unfamiliarity with the culture by the doctors and medical students. This is a key point that has become the thread of their system, that you got to be able to go to the people and gain access to their trust and be able to help them help themselves, empower them by knowing them and knowing what the best way to do. The West Azerbaijan project was really the first key element, stepping stone success in the Iranian system. And here they developed a methodology for delivering medical and health services in Iran, especially to rural areas. And this was the original concept, beginning of the concept of health houses and health workers, or bevarzes, as it's called in Iran. The nuts and bolts, the primary health care integrated network system that was praised by the World Health Organization. Here are the key basics. Priority on preventive care, for rural and underprivileged areas. That was the basic order from the Iranian government. Go do this. Design a system that will help the poor people in this country. They wanted to limit foreign dependence upon pharmaceuticals. We're seeing the same kind of way with the nuclear issue. They want to be independent because the previous 100 years has all been about foreign dominance, starting with the Russians and then the British, and then the United States. They had to integrate preventive and curative programs and create opportunities for the organized participation of community volunteers. And this was implemented during a major war, a major recession, with critical shortages of healthcare professionals and resources. It sort of sounds like what we've been going through in this country, but they were able to do it. In over 20-plus years, they eliminated health disparities. This is the key for me, because the health disparities have not budged again in Mississippi. Now getting down to what are the components, and here's what we're now adapting for the community health house system in Mississippi and now down hopefully in New Orleans and in Arkansas. The critical component is a multi-purpose service delivery point, which are linked level 1 primary care facilities. That doesn't exist in this country right now. We don't have this level of primary and preventive care as part of our infrastructure, and that's why we believe you haven't seen any improvement in the outcomes in Mississippi. Healthcare is provided over time. In other words, they become part of a system that is cared for. They don't just come and go. They come and they become linked into the entire system. And working across all the sectors that relate to the environment within a community, the social determinants of health, we're working with volunteers and community groups. So the level 1 is the gateway. The level 1 is the health house. And that integrates and coordinates health care and meets preventive health care needs of the resident population, because that's where it's placed, and guarantees equitable access to essential services, the public access option. And the successful model of a level 1 is a community health house. The community health house services are early detection for hypertension, diabetes, and other conditions. Right now, people don't get that because they don't have money to go to the doctor, and when they go to the emergency room, it's too late. So we've got to provide them these services up front in an easy way, accessible, to keep them from getting sick. And also to guide them on the appropriate use of going to the emergency room. In other words, there are steps in between that you can do to take care of your health problem, and that saves money and saves you time. Immunizations, health education, and conducting monthly census like the Iranians do of the community. Let's find out what's going on and start to effect changes and mitigate solutions before they become problems. And what can be measured can be funded and fixed. In other words, for the policy people, they've got to see the numbers. And the numbers that we show them about the health outcomes, they have to listen to us. But now we've got to show them, and this is what we're fighting for now, is to implement this as a model and a pilot to show how we can affect those numbers, and people can get well, and we can reduce cost. Something of critical importance is when someone is discharged from the hospital and maybe they don't have any family or they're going back to a poor area. Sometimes that home environment is not conducive to continuing the recovery, or maybe they don't understand what the doctor has told them, the pills to take and when to take them and the regimens you've got to follow. And the community health house and the community health worker can help facilitate the recovery of those people discharged from the hospital so they don't go back into the hospital. We participate in epidemiological studies. We've got to learn the facts. But as what I mentioned to Skip earlier, Dr. Malik Afzali said, no university research should be allowed. It has to be applied research. So instead of it going on the shelf as a study, it goes directly to be applied to helping people get well. That's what those studies are all about. It's not a report, it's action. In the western part of Mississippi, we have tremendous teen pregnancy problem. And I know family planning and those issues are controversial in some communities, but we've got to do something. We just cannot allow this to continue. And we proactively identify environmental situations, like in a home. Maybe there's unducted heating, and so the children who are trying to learn are affected by the carbon monoxide gases, and they can't learn. I mean, this is an environmental social determinant factor that we've got to spot, and the only way you can do that is with the community health worker going into that home and spotting that and getting help to them, because downstream that prevents illnesses and promotes better lives for all. And also to monitor the legally mandated Medicaid and CHIP registrations eligibility for our people. The key component of a community health house are, of course, the community health workers. And there have been numerous successful programs that involve community health workers selected from the community in which they serve. There's that cultural affinity already, and proactively to engage with the community to promote wellness, educate, and empower everyone. Empowerment is the key. And from our perspective, we've included in the training program of our community health workers looking at the social determinants of health, not the medical issues, but the environmental issues that affect how people live. And our zip code, according to the Robert Wood Johnson Foundation, may be more important to our health than our genetic code. These are factors that we've got to look at if we are going to turn people into healthy human beings and productive members of our society. And our training will emphasize the social determinants of health. That's another assignment for you students. And the integration of the health house with the other providers, we provide this link from the gateway to the level 2 clinic to the level 3 hospital. So you've got a whole system that you're working with. Here's how it's charted out. The entry point is the health house to the local community. They connect to the primary care clinic or the existing practice, to the doctor. The community health worker essentially begins to work with them and for them, that level 2, as well as the hospital. So when someone is discharged from the community or from the hospital, they're still part of the system. They're not forgotten, and the community health worker keeps an eye on them and helps them to recover. Now, pardon my PowerPoint graphic skills, but I'll show you how this works. So you have a region with 20,000 inhabitants. They want to go to the doctor. Most of them will then want to go to the emergency room because there are no other areas or no places to go get that care. So what happens? The hospital emergency room is overwhelmed. The more and more the people, that's the only place that they can go to get their care. It just swamps the system. And what happens? The system struggles to sustain. That's what we've got now. That's why hospitals spend tens of millions, or have to expend tens of millions of dollars in unreimbursed care because people wait to go to the emergency room. But with a health house network, same community, same situation, you have a system that identifies and helps them determine what level of care that they need. So they stop first at the health house. The health house determines whether they need to go see a doctor for a certain thing, and then the clinic or the doctor says, well, you need to go to the hospital for tests or so forth. So we've got this kind of triage system to identify need, and people then are empowered to understand where they can go to get the answers the system sustains. This has been proven in Iran and proven in other countries where this kind of system works. It was no easy task to try to sell a program from Iran to the people of Mississippi. So one night I had a brainwave and say, well, this is sort of like the Volkswagen Beetle. It was designed by the Germans in the 30s as a simple transportation device that was cheap and it worked. And in fact, the United States, when we needed a cheap way to get around, the Volkswagen Beetle was a top seller. The Health House is the same idea. It's the equivalent to a Volkswagen Beetle. It was designed in a country that was not too popular, but it's cheap, effective, and it works. And it's simple to use and simple to utilize. So when we made that comparison, it's like the Beetle. People thought, well, okay, we did it once, let's do it again. The first media, we have not promoted this at all for obvious reasons, but the first media that we participated in was an article in the National Institutes of Health, Fogarty International Center newsletter, Global Health Matters. And after that article, the floodgates and the phone started ringing. People wanted going to Iran to help Mississippi. And Dr. Shirley said, after 40 years, I couldn't get the time of day from anybody, and now he can't keep them away. I just got a call earlier or yesterday from National Public Radio. They want to do a series on what we're doing. So the word is out. And most of these articles have been very, very positive. We've even made ralphnader.org commentary. I mean, if we can go from National Institutes of Health to Ralph Nader, I guess we're covering everything in between. But this is what it's taken to get people to understand we got to change the system. And because of this relationship with the Iranians, which is very positive, we've gotten people to notice what we're doing. This is not about Iran. This is about helping poor people in Mississippi live better lives. Skip also wanted me to briefly talk about health care reform. And I had to say, is it really? Because, I mean, insurance reform, yes, it was necessary, but if you looked at all the debates and all the tea parties and all the problems or the town halls, it was not about prevention, helping people live better lives. It was all about, who's going to spend the money, who's going to do this, who's going to do that. We lost that part of the debate. And to me, that's a real shame. Because if we're going to change this system, we're going to cut costs, we're going to make healthier people, we've got to change from curative care mentality to preventive care. Again, it's about the money. So insurance reform is a start, but now we've got to pick up from here, and we hope that implementing this community health house network in Mississippi and showing, and also now hopefully in Louisiana and New Orleans, in response to the BP spill, that we can demonstrate that if you use preventive care and increase access, the country is better off. We spend less money and people live longer and healthier lives. And isn't that what a country is supposed to be about? And some final thoughts. During the course of the past 3 years, we've bumped into some NGOs and got some reporting from the people, especially down in New Orleans, that have been inundated with NGOs. And this is only directed for you students. We kept being told, do not when you come in as an NGO worker, don't communicate that you know what they need. I mean, this is part of what the community, the health worker is all about. They're part of the community and are willing to talk what they need. They're not telling them. And this has become globally a real problem with communities and nations. People coming in, like the United States is being perceived as coming in and telling them what to do. If you go in and ask them, what can we do to help you, it changes everything. The State Department, some of the officials said, well, you know, James, you're not an NGO, which we're not. And what they said, you're a social re-engineering company. And I like that idea because we're working on shifting the paradigm by re-engineering the systems so the outcome changes the way we live our lives, both in terms of healthcare but also in terms of international politics. Suggested reading. To really understand the problems that we're faced with in Mississippi, I strongly urge you to get the book, The Good Doctors, by John Dittmer. This really tells about the whole history of medical care and confronting segregation, the difficulties that we've faced with, and we're still living that legacy that we're confronting with implementing the health house system. And for the Iranian side, the diplomatic side, negotiating with Iran, Wrestling with Ghost of History by John Limbert. He was one of the Iranian, or the hostages at the U.S. Embassy, has been a key supporter of what we're trying to do. And his book is a great read, not only in terms of Iranian politics and the U.S. relations, but also in negotiating and being involved with other countries. You got to know your history before you can engage in the dialogue. Well, that's what we're working on, and we've enjoyed it. It's been challenging, and hopefully you'll hear more from us in the coming weeks and months ahead. And I'm happy to take any questions.
All right, questions. Yes, all right. Hold on just a minute here.
Hi, thanks for coming. We really appreciate it. My name is Dustin Choate. I'm a member of Class 6. My question pertains to unique health challenges in the United States. Could you speak to this model and how it could address things like childhood obesity, the early onset of diabetes that are related to cultural decisions and
the changing people's attitudes about lifestyle, about not cooking with lard, not eating fast food only, or maybe even helping the community get a fresh food market so they can buy fresh vegetables. That's part of how we address childhood obesity, as well as encouraging people to build walking paths. But you got to understand that, to exercise, you got to understand that the areas that we're dealing with have no resources to do that. And oftentimes they don't have the ability to go to get them to the market to get fresh vegetables and food to help address these issues, not eating potato chips, but eating an apple. In fact, in the early days when Dr. Shirley was working on community health clinics, they often wrote prescriptions for food. So they could be reimbursed. But in essence, we're going to have to do the same idea to get it at the root of the problem and write prescriptions for behavior and for nutrition, and do it early. And that's what the community health worker in the health house will do. It's also a kind of an outpost within the community where it becomes the centerpiece of that community for health-related and health wellness kinds of activities. It's an ever part of the presence. One thing that we are planning in terms of implementing the health house networks within the communities is that we first engage the entire community and talk about, well, what do you want to do? What do you want to improve? And then we do a strategy mapping session. Okay, if we're going to get there, we got to go from here to here to here to here and get their buy-in as stakeholders to make this happen. So when a student or a parent, a teacher says, we got to address the obesity problem, we say, okay, how can we do that? You got to be part of the solution.
Questions? Any other questions? Yes.
Hi, thank you for being here. I'm a Class 5 student. My name is Heather Malvo. And you talked about how empowerment is key, but can you share with us some of the steps that are being taken to empower the people in Mississippi?
Well, I think that, as I just alluded to, that part of the process of implementing a health house is going to the stakeholders and talking about it's your responsibility to improve your community's health. And oh, by the way, we're here to help you do that, providing education, providing contact with resources to bring in to facilitate empowering the community, providing opportunities for learning. We're envisioning in some ways the health houses to become learning centers so a parent or a child can go in and read about the healthcare profession, becoming a doctor or becoming a healthcare worker. Something that we're working on for our community health workers, who again are coming from that area, is that part of the curriculum for the community health worker is going to be integrated into a public service degree program at Jackson State University, which would be perfect for also the Clinton School. But these people who are from those communities and maybe have lost their jobs or not have any opportunity are trained to be community health workers. They serve their community and then have an education track to get a degree and go on into the primary care profession, and that certainly is a growth industry. We've got such a shortage, we need more people.
Yes, yes, sir.
Paul Halverson I'm the State Health Officer from Arkansas, and I want to thank you very much for your presentation. It's quite insightful and I think very exciting. I guess one of the questions that I would have is, as you've rolled this out in Mississippi, what level of interaction have you had with the State Health Department, and how can you see working with public health in this kind of endeavor? And I guess one last question relates to long-term sustainable funding for this activity, which, again, it's very exciting. The issue is, how do you keep it going?
How do we keep it going? To answer your question, we are working with the Department of Health, but primarily at the regional level. We're trying to steer away from the politics at the state level, and we've got so many good personal relationships with public health directors within those regions that they become an integral part of our service. In fact, a grant proposal that we've, knock on wood, hopefully we'll be getting shortly for Greenwood. The Department of Health in that region, each of the county offices become a virtual health house for us with the full participation of their social workers and so forth. One thing that we've got to reiterate, this is an inclusive model. We are not excluding or replacing anybody or any institution. We're adding on the front end a way to better maximize the resources and capabilities of the existing institutions. We will work with clinics, physicians at that level in hospitals, Department of Health. This is a very gluey, combined kind of approach. That's the only way that we can work this. We're not trying to exclude anybody. We've got to have all the stakeholders involved, including the Department of Health. And we've got very good response, very, very positive response. In terms of sustainability, that's the issue. Because if we're able to tap, which hopefully Skip will help us through President Clinton's efforts, if we're able to tap some of those preventive care dollars that have already been allocated for these kinds of programs, we've got an answer. How do we, how we can sustain this? But the cost of a community health house annually, the staffing and the resources, not the building, because we have other alternatives there, options, is about $250,000, the entire thing. And if you start looking at what other health care costs are, you combine that with the savings of people not getting sick, it's a bargain. And because we're based on a curative spending idea, people thinking, well, that's cheap, something must be wrong. The Iranians did it, and they had no money. They succeeded. Why can't we?
Yes. Mr. Banks.
Hello, I'm Patrick Banks. I'm also a student at the Clinton School. Something we learned in our curriculum is that to create that gluiness or cohesion you talk about,
Coined a word.
Yeah, you have to do what you just said, which is empower the disadvantaged people, but you also have to reach to the privileged, empowered people and help them to realize that they need to give a little bit. What sort of tensions are you sensing from the hospitals, the facilities that are making all this money right now, who understand that if preventative medicine works and is implemented, they won't see as many patients on the back end?
Well, what they won't see are the people showing up in the emergency room that they don't get reimbursed for. That's the one thing. The hospitals we've been working with, I mean, everyone in Greenwood and Belzoni and in Bolivar County, when we've talked about what this can do for them, they say we want it. So there has been no resistance because we prevent those unreimbursed visits. And when the doctor discharges the patient after surgery or what, they have some place to send them. They don't have to keep them in the hospital. Because the reimbursables may not, there comes this cutoff point where that's, profitable. And so we become a team member with them and facilitating both reducing cost and improving the outcomes of their patients as well.
Ladies and gentlemen, let's thank Dr. James Miller.